I'm really grateful to SCTS and Egyptian Society to give this opportunity to give a lecture. And I'm also grateful that my picture in the program is from my younger days. But yeah, I've grown older. I've grown much older in the last uh, few years since we met last time in Egypt. Things have moved on. We have moved from Heartlands Hospital to Queen Elizabeth Hospital. We have moved from having a conferences, sitting together, talking to each other, and I moved to this sort of a format, sitting in a room and trying to see the pictures on the screen. And then something has happened to the Suez Canal since we visited, and we found this ship stuck there. But we move on. So I'm just going to talk about chest wall resection. And as Shri mentioned this morning in the anatomy lecture, that the chest wall is quite a dynamic structure and is involved with ventilation. And there are so much in the chest that I'm surprised that we don't see more tumors than actually we treat. And because there's a lot of ribs, bones, and muscles, diaphragm, and other organs. Well, when we talk about chest wall tumors, majority of them are either metastatic or they're coming from the lung. But then there are some primary chest wall tumors, and they are quite rare. They're just about 5% of all thoracic neoplasms. And majority of them are malignant, and they're going to be malignant more likely if they appear at the extremes of the age. And this is a common theme that they're slow growing and they're misinterpreted. Majority of time, it is just pain, discomfort, and that's what it is thought to be. And this is the variety of chest wall tumors people will see, and the location, the size, and the pathology varies from person to person. And these are the various types divided between bone and soft tissue tumors. And as I said, they could be malignant, and very rarely they will be benign. About 5% of the resected lung cancers will have invasion into the chest wall. And that's another sort of a discussion, how you actually interpret the scans or intraoperatively how much you are going to resect. The treatment for the primary chest wall tumor remains a multimodality, and surgical resection plays quite a big role in it, particularly the ones which have not metastasized. So in some sort of combination or permutation, surgery will be advised. But by and large, if you look at it, there depends what sort of tumor it is and what response it will have to chemotherapy and radiotherapy. And as you see, the majority of tumors which we will be dealing with as thoracic surgeons are chondrosarcomas, and they are unresponsive to chemotherapy and radiotherapy. So the onus is on us to resect these tumors with clear margins, because if we don't do that, then there is little benefit. The other ones, which are soft tissue sarcomas and also osteosarcomas, they are quite malignant. They normally metastasize by the time they will come to us, and hence we don't see them very often. But if they do come, the principle remains same, that wide resection needs to be carried out. The desmoid tumors is a difficult beast to treat, and I will advise stay away from it. No matter how radical you are, they will reoccur. So let that be treated non-surgically. There are a lot of treatment modalities available, and only if they are big or causing symptoms should we try to resect them. Majority of them should be coming to you from the multidisciplinary team dealing with the sarcomas. The ones which come to you directly should be again referred to that team, because it's a quite specialized treatment. Majority of them, or I would say all of them, will require a biopsy unless you can excise a small tumor completely with adequate margins. And as I said, unless they have metastasized, they are resectable. Very rarely we will undertake resection for palliative reasons if the tumor is large and fungating and causing quality of life issues. Now, the principles of resection, and I'm just going to spend a time on this. The most important thing here is that do not undertake a resection if you cannot achieve the resectable with the clear margins. That's most important. There's no point of leaving a tumor behind because they they are not very responsive to radiotherapy or chemotherapy. So make sure that you can resect that. And for that matter, the preoperative planning is essential. So sit with your radiologist and assess the tumor and make sure that that can be removed and blocked with clear margins. And we will discuss what margins are we aiming for, but by and large, we go for anything like about 3 to 4 centimeter in size, depending on the location and depending on the histology. And once you have created a big defect with a radical resection, there's a defect in the chest wall which needs to be repaired. And the reason is that we need to maintain the structural integrity and also the functional integrity of the chest wall. Because the bigger the defect, the more compromised are the mechanics of ventilation, and we need to make sure that they are actually sorted. And then once you have filled that defect with some sort of prosthetic material, you need to cover it with a soft tissue, not only to have a good cosmetic outcome, but also to prevent the infection of the underlying prosthetic material. Then also you need to consider where the resection is. And if you are taking too many of the ribs posteriorly, then you should be mindful of the stability of the spine. And if you are taking something where the tip of the scapula is, then you make sure that that doesn't get impacted and how you deal with it. Similarly, what do you do when you are taking a manubrium out? What happens to the clavicles? And similarly, lower down where the costal margin is, you disrupt the costal margins, there is a very high risk of the developing hernias, and also how you implant the diaphragm back where it should be. And if you are working somewhere in the thoracic outlet area or higher up, make sure the phrenic nerve is not damaged because you're already damaging quite a bit of chest wall, and the functionality of the diaphragm is important. And once the prosthesis has gone in, you need to make sure that the prosthesis is actually stable. You don't have either too tight prosthesis because that will cause pain and limitation of ventilation, but also if there is the prosthesis is loose, then there will be paradoxical movement. Sterility has to be maintained. This is one procedure where you should minimize the footprint in the theater and also make sure that you are properly gowned and covered. So histology, as I said, is important. We need to know what it is because that will dictate whether the patient needs any new adjuvant treatment or not. And also that will dictate how wide the resection should be. If it is a grade 1 chondrosarcoma, you don't have to go really too far beyond the tumor. You can probably be okay with 2 to 3 centimeter margins. Make sure the patient is fit for surgery. It's a major operation, and he should be able to undergo a major operation and should have a good lung function and exercise tolerance and beware of other comorbidities. Look at the radiology. It's important to see the extent of the tumor, to see where you will be entering the chest, and also the relationship to the other structures around, and the soft tissue flaps which you're going to use, and the blood supply, that all needs to be assessed. The consent is important because these are actually a life-changing operations for the patients, and you need to talk to them about what you are going to do with the chest, but also what prosthetic material you're going to use and from where you're going to get the flap to be inserted. And that is important. Somebody playing a golf and you're going to take the latissimus dorsi out, that will have its consequences. So we need to discuss that. Talk to the team, tell them how you're going to position the patient, what instruments you will be requiring, what other surgeons you are anticipating to come into theater, spinal surgeons, or plastic surgeons or what kit they need. So it is a proper communication which should happen. And then how you position the patient and how you make sure that the positioning has to be changed. For example, patient may be spine to start with, but then needs to be turned to the lateral position for harvesting the flap. So that all needs to be looked into. And the pain relief is the most important thing you need to discuss with the patient and the anesthetist. And then you should know that you will require a surgeon from the spinal team, and then make sure that he's available. And this is the important bit. You need to make sure that you do not enter into the tumor. Okay, so once you have disrupted the tumor, you have done a huge disservice to the patient, because these tumors will seed and they will grow. So make sure that you look at the CT scan, you know where there is no tumor, and that's where you enter. And I always advise that make a hole far away from the tumor, put your finger in, and that your finger should dictate how you're going to go all around the tumor and take it out. Your finger is the best way to guide you where your incision should be. And I'm going to again stress on this fact: do not disrupt the tumor. So the surgical strategy is, what is the extent of resection? As I said, that as wider it is, the better it is. But obviously, if the tumor is somewhere here, you cannot go 4 centimeter laterally, because medially, because you will go into the spine. And similarly, you do not need to really go very far above into the neck if it is in the thoracic outlet or in relation to the first rib. So you need to use a bit of a common sense there. But the main issue here is that you should aim to get a clear margin, no matter how far you have to go. And if you need a spinal surgeon for that matter, get him. When to reconstruct? The tumors, the defects at the back can be left alone. You don't really need a reconstruction. Or if there is a tumor from the first or second rib, you don't need reconstruction. But by and large, majority of tumors anteriorly, laterally, or the costal margin will require some sort of reconstruction. So 2 or 3 ribs coming out will create a big defect, and you need to reconstruct. Whether you construct it just without any rigid material like cement or the bars, metal bars, or you just use some sort of a mesh, that is again up to you, and you will learn over a period of time what suits the patient and you the best. Now, for example, in this patient, big defect, somebody has just used a soft tissue, a soft patch, and that is not right, because there was a lot of flail, and every time patient would cough or sneeze, it will pull and will cause a lot of pain, and this patient had to be reoperated. So this is the variety of prosthetic material we use. So it could just be a mesh, it could be a mesh and cement into the mesh, pocket of a mesh, or it could be a biological patch, or it could be various types of metal bars. There are plenty of them which are available, or you can use a combination of all that. You have a mesh, you have a bit of a cement, and then there's a bar going through the cement, so sort of a composite graft which you can use. And this is what they look like. So you can see that is just a cement mesh incorporated in the Marlex mesh, and these are variety of other bars used. But soft tissue cover is essential. So have a really good oncoplastic surgeon who can work with you, because the defect you make, as I said, will depend on the size of the tumor, but also on how much margin you need to use. So if you have a good plastic surgeon, you won't be scared to make a big defect, because he will be there to make sure that that is somehow covered. So that gives you more confidence to be radical. So you have to be radical. Cover the prosthesis with good soft tissue, and that will help you to resist infection, will give really good cosmetic results. Patient will recover early, and if required adjuvant treatment, he can have that. And there are a lot of soft tissue reconstructive options available. If there is a no skin defect, then you have latissimus dorsi, P major, serratus muscle, oblique, external oblique, or a mental flap. And that works quite well if you're removing something like a lower part of the sternum. Or if you're creating a skin defect, then you need to use various musculocutaneous flaps, and then they can again be either pedicled or free flaps. And there are plenty of them, and this is an anterolateral thigh flap, which is a very, very good flap. And then there could be some other muscle press grafts, and I'll just show you a few examples of that. And at times you will be using more than one flap. And which flap to use depends on the age of the patient, comorbidity, site, and whether patient has had a radiotherapy before or not, or any surgery before, and also the availability of that sort of flap. So to give you a few examples, so this is a patient with a chondrosarcoma lower down, and this is the site of the biopsy, and you have to incorporate in the incision, and this is what you have done because it is the lower part. You have taken up quite a bit of a diaphragm out. So big defect, costal margin has been completely disrupted, and that's what you have done. You have put a metal bar there, and then the latissimus dorsi muscle has been used to cover the defect. Now, this patient has got radiation-induced sarcoma, and obviously that skin will be lost as well. So you can see there is both skin loss as well as muscle loss, and then you have done your bit, and then the latissimus dorsi myocutaneous flap has been used. And this is another one where there is huge amount of skin loss because of the recurrent breast cancer, and myocutaneous flap may not be enough, and for that matter, a split skin thickness graft has been used. So this is a patient who had a radiotherapy, and so we can't use the latissimus dorsi in this patient. So after you have done the repair, the plastic surgeons used pedicle tram, and that was transposed to that area to cover the defect. And then similarly, there are free muscle sparing trams. So the idea of showing you all these is that it is very, very important that you take the tumor out with a wide, clear margins. The defect in the chest wall gets covered with various types of prosthetic material as I'm demonstrating, and then make sure that that is covered with really good soft tissue. Now, this is a patient who had been sitting at home for many, many years with this huge, large chondrosarcoma growing and then fungating. And this is badly infected. And again, as I said, the chondrosarcomas, you'll find that they actually are localized and can be resected. And that's what was carried out. And so a lot of time is spent in preparing, in positioning, and planning how you're going to remove it, how you're going to repair, because this is infected. You can't put a lot of material in. So we have used a biological mesh, but you need to stabilize the chest wall as well. So variety of options, and then you have a good outcome. So lots and lots of examples and lots of options available. So the bottom line is that make sure you have a good team. And this is another classical example where the patient with a very high grade pleomorphic sarcoma appeared with pleural effusion. And actually somebody put a drain in, and the drain went into the tumor. So again, the thought process is that you have to now ensure that you include everything and block in that mass and remove it. So you can see the sort of a funny shaped skin incisions and going in, removing everything, and making sure that you have a good cover. And this patient was one of the earliest one we did, and he's still alive. And the important bit here is that make sure that you don't get into that mess, but if you do, then you have some sort of a lateral thinking and get the tumor out completely. So just to give you another one, so this is a patient, as I was talking to you, has got a tumor, a leiomyosarcoma right at the back. So here you should be very much know that you will require a spinal surgeon, and then you prepare the patient accordingly. And again, this was going into a part of a lung, so unblock resection of the whole mass, stabilize the spine. And as I was saying, there's a big defect at the back. You really don't need a rigid reconstruction here, because that gets stabilized as the patient is sitting or lying down. So you just a soft mesh there, and then a really good cover with latissimus dorsi. Now this is an example how you work up a patient. So this is a lady who has got an Ewing sarcoma, and she will require post-operative radiotherapy. We are aware of that. And there's a kidney at risk, there's a bowel at risk to get radiotherapy. So what we have done, we have put an expander here on the material which we have used, the prosthetic material. She goes after getting all the treatment. We bring her back after she had a radiotherapy, and we deflate this implanter and take it out. So another example where the tumor actually has grown to that size, and you can take it out. Again, another example, chondrosarcomas, no matter how big, will be resectable. So go ahead with it. So it's pretty much a multidisciplinary team effort where you get a patient discussed in a sarcoma, make a diagnosis, get an adequate imaging, and make a plan. And if that plan includes surgery, bring the patient to a joint clinic where thoracic surgeon and the reconstructive surgeon see the patient together, and then you operate on the patient. And then a good dedicated team should be there making the patient mobilize, and all the other chest physiotherapy which is required, because you don't want these patients to get bronchopneumonias, and then they start spiraling downwards pretty rapidly. And the other important bit, which I forgot to tell you, was that when you are operating on these patients, just make sure they don't get any air leak, because that is quite disastrous, I would say, because once they start getting air leak, the infection of the prosthesis will happen. So make sure that when you are taking a bit of a lung out, that the patient does not develop air leak. So post-operatively, pain control is the most important thing. We need to keep it in mind. Hemodynamic stability, because that is what will make sure your flaps are working nicely. And then positioning of the patient is important, because if you have the flaps you have used, the patient's position will be dependent on where the arm is, where the how much flexion of the belly is there. So all that will go in as dependent on which flaps have been used. And then we have a very sort of a protocol, well-written protocol, where how we ensure the flaps viability. And these are little different than the routine breast reconstruction flaps, because here you have been working on the chest, number one. Number two, the patients have some sort of a pain control mechanism in place, and that plays with the hemodynamics, and that can further affect the viability of the flap. And also, as I said, you have to make the patient cough, sneeze, and all that. So just keep that in mind. And then look for the seromas. And if required, once the patient goes home, then you need to discuss the adjuvant treatment. Few of them will require. So if you look at the literature, the results are quite gratifying now. They are getting better and better. But you still see that the risk of getting respiratory complication is quite high. About a quarter of these patients get some sort of respiratory complications. The wound infections still happen. And if the patient gets into these complications, then the mortality is high. But as I say, if you review the literature, the results are getting better and better. At the end of the day, what is important is that you make sure that you have a team who can look after these patients with complex operation. So this is the complication, which is chronic ones, that you have the bars breaking down. And this is something which we observed. And I think it is more related to sort of a fatigue fracture. And it happens after 2 to 3 years. And that has put us off to use these bars. So we have gone back to use methyl methacrylate and cement. What we have learned over a period of time is that you need a very, very thin layer of the cement. Okay, so this is a disaster. This is very, very thick cement plate, and that's not what you should be using. So very, very thin plate. The plate should be about 2 to 3 millimeters smaller than the defect so that it doesn't rub against the defect and cause pain. And if that is and the sterility is maintained and you cover it nicely, the chances of it getting infected is almost nil. So I think I've run out of time. So take home message is that a team of good surgeons, oncologists and radiologists working together with the nurses, with the chest physiotherapist and anesthetist can can give a good operation to the patient, and patient can benefit from that. So unless the metastasis is present, most of the chest wall tumors are resectable, and particularly the chondrosarcoma, no matter how big they are, they don't invade, they just grow, they can be removed. And it is so very important to have a really clear resection margins and then cover it with a skeletal or soft tissue reconstructions. If you adhere to few of these, the outcomes for these patients is more than satisfactory. Thank you very much.